Good morning, good afternoon, or good evening, and welcome back to Bariatrics and Beyond, the podcast where we talk about life before, during, and beyond bariatric surgery. So grab yourself a drink and a healthy snack, because on today's episode, we have a member of Team Rios. We have the anesthesiologist, Dr. Juan Gonzalez. How are you, Dr. Juan?
Hi. Fine. Thank you. I'm doing great. Thank you.
Good. Well, thank you for being on the podcast. I think this is going to be a really important episode because a lot of people, whether they're coming to us for bariatric surgery or plastic surgery, their number one fear, because I ask everybody all the time, their number one fear is that they're not going to wake up and they're scared of you guys, the anesthesiologists or the anesthesia. So can you today, we'll shed some light on that whole topic. But first, would you like to introduce yourself? Tell us a little bit about you, where you're from, what do you like doing, and all that fun stuff.
Yes, of course. Well, my name is Juan Gonzalez. I am from northern state in Mexico. It's called Chihuahua. So it's one of the largest states, if not the largest in the whole country.
Is that where Chihuahuas are from?
I'm sorry?
Is that where the dog Chihuahuas originated from?
I'm not sure I can actually answer that question correctly, but I don't think so.
Okay.
Nevertheless, I could not vouch for, to be correctly.
Right. I would just say, we're responsible for children. I would just claim it, but continue.
So I was born in Ciudad Juárez, which borders El Paso, Texas. And as a border city, I have always been a border city boy. So, moving from Ciudad Juárez and El Paso into Tijuana and San Diego feels almost like home.
Right.
Sort of a way, because it's, it builds on that border city kind of lifestyle.
Yeah, that makes sense. Did you spend a bit of time, in the US growing up? Did you hop backwards and forwards?
Not really, no. I only grew up in Mexico, so I learned, English when I was at home from, just as far as I can remember. But my schooling has always been bilingual. I mean, thanks to my parents on that. Yeah, that was a nice investment. Thank you very much. It really opened a lot of doors.
Yeah.
So, and I was always close to the border, but what actually taught me English was, listening to music and playing video games. Yeah. So, yeah.
That's amazing. So is that kind of like your hobbies? Are you big into video games and music and all that kind of stuff?
Yeah, actually, I do decompress playing video games a lot. Most of the time when the moment I get home right after surgery, I usually leave all my stuff next to the door, then just come take a bath, take off my hospital clothing, and we'll go take a shower. Then, maybe come back and start playing something. And for a while there, I'll just fixate on playing something. And sometimes if not most of the time, I have chat groups with my friends. And we usually get together online and decide what we're playing, and we will be playing together. And, maybe after an hour or so, we'll just, each one of us will just switch into their continuous daily activities, maybe wash clothes or make dinner, or, we'll just keep on moving.
You know what? I've interviewed quite a few of our surgeons and doctors, and a lot of you guys like to play video games. It's like a trend. I'm like, okay, I see it. And Dr. Ortiz, our bariatric surgeon, he loves video games, but he's now doing robotic surgery. And I'm like, it's just got to be like playing a video game for you. He's like, yeah, it is. I love robotic surgery. It's like I'm playing a video game.
Yeah, it actually, in my personal point of view, I think that it does make things a little bit more simpler. Sometimes whenever you are manipulating some sort of camera or some sort of instrument, and when you're using your hands, sometimes the camera axis are inverted, or it's actually a little bit easier for you to, for your brain to have this previous wiring on how to communicate with your hands. And this makes operational things just, a little bit more fluid.
Yeah, that makes total sense. So can you share your journey? How did you become an anesthesiologist? Like, what sparked it in you? How long did you go to school for? Give me all that background.
Sure thing. I started going to school in 2005. It's been a really long journey. uh, you know, medicine in Mexico is really, really long. It was 7 years for medicine. I studied in the Autonomous University of Nuevo León. So that is further out east. Then I specialized in anesthesia in that same university in the anesthesiology program. And that's, even maybe I was the last generation that was 3 years long. Then it switched into a 4-year plan. But I was the last generation that had a 3-year plan for anesthesia. I guess that after that, I did some training in cardiac anesthesia too.
Oh, wow.
Yeah. And I did a lot of training in pain and post-op pain and trainings everywhere. But most of the time, they were within or inside the actual career training. So it's been a long journey, but it's been really fun.
That's awesome. What made you want to get into the plastic surgery side of things?
Well, that's actually even more interesting. So, because it's kind of personal.
Yeah.
Plastic surgery, as you might know, are really long surgeries, right? Plastic surgery is really, really long. So, something that I like about staying in particular long surgeries is the fact that I can follow my own patient for prolonged periods of time. So that is to say, I don't have to leave my patient because it gives me the sense of security that the patient I came into the OR with is the patient I'm going to be leaving the OR with. So some other surgeries are shorter, and some other anesthesiologists would rather have shorter surgeries, maybe like C-sections or, maybe knee replacements or abdominal surgeries or, broken bones, or just because we need anesthesia for anything, right? And for everything. So what I did like is that I didn't like moving around and having to learn about more than one patient at the same time. Because for me, particularly, every single patient you make anesthesia for is like painting a whole new painting. So switching from having, making this really, wonderful fresco into some really wonderful claroscuro is just so, it's different. It's like changing your technique. So I would just rather stick with my own patient instead of changing patients.
Yeah.
So when I discovered that plastic surgery actually allowed me to do that because I would stay with my patient for so long, it would completely start my shift and then end my shift. And that way I never had to switch with anyone. I never had to switch out with anyone. And I could finish my surgery, by myself.
Right.
And I could do the thing that I really, really most like about plastic surgery, which is waking up my patient and, like just tapping on their shoulder and being like, hi, are you doing all right? Are you having pain? And that's my favorite part of surgery.
Right. Well, that was going to be my next question. What is your favorite part? So it is kind of cool, I will say, because going into it, I didn't really know much about it, but I remember when I first woke up from my first surgery and the anesthesiologist was there, it was just so comforting. You guys, as nervous as we are, you guys really do calm our nerves. It's so nice and comforting to know that you guys are with us the whole time. You're like, you know what? I've got you. Don't worry about it. And I feel like you guys are the last people we see when we're going to sleep as well. And that just, it's very, very reassuring to know that you guys have us the whole time. I love that.
Yes. And for us on the other side, it's really, really comforting to know that we're going to be there for the whole time, because we can, if for any reason we were to change, because maybe in public sector medicine or maybe in other settings where you would have to change anesthesiologists whenever you are finishing your case or passing your case on to somebody else, it places a toll on how you're going to be explaining what started, how surgery went on, how surgery developed, what have you used. what have you not used, what has happened, what hasn't happened, what you're expecting to happen. So that way, if you stick to one single person, it stays all the time in your own mind. And that way you have control over whatever it is you have designed on doing. And this is why, pre-anesthetic consultation is so important, because sticking to your plan and being able to develop it throughout surgery from the very, very beginning, from the moment you meet your patient to the very, very last stage of surgery, this is where you feel that you have completed, your whole painting.
I love that. And yeah, because handing it off to another anesthesiologist, it's like at that point, there can be room for error. It's just one slight miscommunication. You may have handed it off correctly, but they've received something wrong. So yeah, that makes sense. It's very streamlined and like you're in control the whole time. So that makes sense. So can you take us through what patients should expect when going in for surgery? When do they meet you from A to Z? What is your role throughout their procedure?
Okay. So I think that I had one of my mentors. She was a really, really great teacher. She used to say, and when we were just really, really young, just first year anesthesia students, she used to say that anesthesia should feel like going to work. Mm-hmm. Coming into anesthesia or coming into surgery and going into anesthesia should feel like coming to work. And, the first time I heard that, it was like, how is that, relatable to anyone? But then she kept on saying, you should be able to feel that you woke up on a normal day and that you just came into the office like you normally would, and that you started working like you normally do, and that you kept on working like you're expected to do so. You ended your work at the end of the day, and then by the end of your whatever cycle is, you just finish your job and then hand it to your boss and say, I'm finished, boss. Can I go home? And then your boss would say, yeah, sure. Please feel free to do so. So trying to make anesthesia feel like something that we would do normally, to decrease the anxiety, to not feel worried about coming into work, to not feel worried about coming into surgery, to not feel worried about pain, to not feel worried about waking up, to not feel worried about recovery. All these things, it should be able to, just give you ease. And this is what we're aiming for. So the first time we meet is particularly at pre-anesthetic consultation. So this is something that I really, really like because each anesthesiologist has their own manner and their own way of doing things, right? But for our team particularly, we, Dr. Rios and I, we like doing pre-anesthetic consultation on the day before surgery. So I like to meet our patients before surgery on the day before surgery. This usually takes a little bit of time, on the day after surgery, because except unless it's a Monday. But we'll get over that in just a moment. But usually I will meet you at pre-anesthetic consultation at Andre's office, right? And this is where I will usually be talking to you about all your previous history with anesthesia, whatever it is you like, whatever it is you don't like, how many complications, if you have had any, what you would like to avoid, how you would like things to develop, if you are taking any daily medications, if you are having any, any illnesses in your medical background. So this is where we do all your medical checkup and all your medical history, where we start digging into our medical past and into everything, because medicine itself, and particularly the interrogation process, it's never meant to be judgmental.
Mm-hmm.
Medicine is meant to be open. So this is why we always ask our patients to never withhold information from your questionnaire, right? Everything you're answering on your paperwork, we get to read that first, and then we get to ask about it once we are seeing each other face to face.
Right. Got to be truthful. It's like, you guys, they're not the cops. They're not going to get you in trouble. Like, you just be super honest.
We're not on the bad side.
Yeah.
But I always tell our patients, anesthesia is made for our brains, and all our brains are different. So all our brains can tell, maybe like different sets of color apart from each other, right? So maybe someone who is already sensitized to different shades or colors of blue will probably break up anesthetics that are blue colored faster. Not that they're colored, but this is, just to exemplify things.
Yep.
So maybe I would give your brain something that is some kind of, shade of green, because it would probably not be able to tell it apart, right? So, and this is how we try to work through everything you have had in the past, allergies, maybe recreational drugs or recreational exposure to anything, any kind of smoking history or drinking history, or prescriptions for chronic pain medication. So everything that we try to understand at this point in process is precisely made so that we can make anesthesia work for your body instead of the other way around.
Right. So it's a different cocktail for every person, right?
Yes, it's completely different. It's completely different for everyone. And the way we will metabolize things, and the way we will benefit from different pain medications, from different inductors. Inductors are medications that we use to set into the anesthetic state. So depending on how we benefit from these, we use those or change the combinations or the dosage of how to use those. For example, you wouldn't give anyone anything that has, maybe hepatic metabolism if they were having trouble with their liver. I would probably switch to something that has kidney metabolism or pulmonary metabolism, right? So that we could skip out and not be giving your liver extra work, right? So then I could probably switch into other types of medications so that I could make anesthesia softer and less and have less of an impact.
Right. That makes sense. So the day of the pre-op appointment, you go through all that, and you figure out what cocktail they need for the next day. Now let's fast forward to the next day. They're in there in the morning, and they're waiting for surgery. Do you meet them again before they go to the OR, or you see them in the OR?
Yes. Usually, so even on the day before surgery, we will set on deciding the type of the technique that we're going to use. Because this can actually be different from everyone, right? We have a lot of different types of anesthesia. We have local anesthesia, regional anesthesia, general anesthesia, multimodal anesthesia, a combined type of anesthesia. So usually what I do, and I think that what very few other teams do, is that or very few other anesthesiologists, maybe outside in their practice do, is combine types of anesthesia. Particularly for me, something that I really like is to combine types of anesthesia, because when we are adding combined types of anesthesia, we get to experience or synergize the effect of anesthesia. So, for example, a lot of other patients will ask me if they're going to get an epidural block. A lot of other ask me if they're going to get general anesthesia only. And this is particularly where we talk on how pain is made, how pain is perceived, how pain is transmitted, how pain is evocated or remembered or recalled. So usually by using more than one technique, I can work on more than one mechanism of action through which pain is modulated. And that way I can prevent more than one type of pain creation process, right? So it would be like maybe keeping you unconscious and protected and immobile from the use of general anesthesia while having an underlying block, which actually is providing us with the numbness from the area that we are providing anesthesia for. And that way, most of the time, the pain markers that are released when we are working on the tissue that we are touching or severing won't even be able to be transmitted up to the brain. And if the brain doesn't perceive pain, the rest of the body doesn't perceive pain. So this is the intention, right? To block off both areas, not only just one, like the brain where we perceive pain, but on more than one area, so that we can work with more than one process. And that way we can prevent pain even deeper.
That makes sense. So can you explain to us, because you did mention the epidural, can you explain to us the difference? Because like you said, this depends on, what you need, but what is the difference?
The difference between an epidural and what else?
And there's like the regular, however you, the other way you do it. I don't know the other way. Is it like through the IV? Is it? Yeah. Okay. Is it like a gas mask? I don't know, actually.
Yeah. Okay. So for example, different types of anesthesia, right? We have general anesthesia, we have regional anesthesia, and then we have local anesthesia.
Okay.
Local anesthesia we would use for very small things, very basic stuff, like maybe a root canal or maybe like an ingrown toenail, or just something that is a very, very small area that, maybe even just suturing, something really, really small.
Right. And you're completely awake.
Completely awake. We're completely awake. Just this one area is particularly out. Regional anesthesia, on the other hand, is a little bit larger because we're giving anesthesia to a more extensive region, like for example, the whole thorax, or maybe from your belly button all the way down to your feet, or maybe a whole arm, okay, or maybe both arms. So regional anesthesia will provide anesthesia for a given region for a given moment in time, and general anesthesia is the way of providing anesthesia for the whole of our bodies and the whole of our minds. Okay? So inside or within the regional anesthesia, how can I explain this? In the regional anesthesia category, we have spinal blocks, we have epidural blocks, and we have peripheral nerve blocks. So depending on the type of needles and where the needles are placed, we can usually decide if we're placing spinal blocks or epidural blocks. Spinal blocks, for example, are placed inside the spinal cord, and epidural blocks are placed on top of the spinal cord. Okay? Try to imagine like when you are applying like lotion on your hands, right? So, for example, when you use lotion on your hands and you use like maybe 1 pump or 5, and then you just like rub it around your hands, you have to wait for the lotion, right, to be absorbed. You can't really push the lotion into the skin. Okay? So this would be the equivalent of using an epidural block. So when we are using an epidural block, I'm placing local anesthetic on top of the nerves, okay? So to like coat them. And we use combinations of local anesthetic with morphine or other opiates to prolong pain relief. And that way, your body can decide the speed at which it will draw the anesthetic in, and it can decide how deeply or how strongly it's going to absorb it, right? Spinal blocks, on the other hand, are for much deeper blocks. For example, I would give you a spinal block maybe if you had a broken bone or something, because spinal blocks can also be soft, but they tend to be more immediate. So depending on your anesthesiologist, for example, you can have an anesthesiologist who is very, very good at placing spinals and having very light or very soft spinals. For example, on my preference, I would rather use epidurals because I like the fact of using continuous epidurals. Continuous epidurals means that I will be placing an epidural, and then through there, I will be leaving a catheter, which is really, really small and thin. Mm-hmm. And that way, I can use anesthetic as long as surgery is lasting. So as long as surgery is ongoing, I can use local anesthetic to different concentrations. And different concentrations means different effects. So we can have more or less block of movement, for example. Some types of local anesthetics will block off pain faster than they will block off movement. Some types of local anesthetics will block off movement almost instantly, okay? So depending on the type of surgery you're having and the type of recovery you want is how you choose your local anesthetic or how you choose your own technique. Mm-hmm. Okay? Does this make sense?
Yes, absolutely. So let me ask another question, and I'm sorry if I'm asking really dumb questions.
No. This is not dumb at all. This is perfect. I really, really love this.
Okay, cool. Because I think what happens is when people say the epidural, right? Mm-hmm. My mind goes to when there's a pregnant woman, right? And they're awake and that big old needle goes in their spine. Is that what happens with you? Or are you asleep first and then you insert the needle in the back? What's the process there?
Yeah. So let's try to switch everything and how we would do it in our team, in our practice for plastic surgery, okay? Normally, whenever we think of epidurals and we think of women and we think of obstetric surgery, we think about this because this is the most common scenario where we have the placement of epidurals, right?
Yeah.
But usually I usually ask my patients, have you ever heard, for example, of an epidural being painful in a man? And they will usually, take a while to respond and say, not really, no. And the reason is that usually whenever we're having obstetric surgery, we don't use or we skip on the use of sedatives or pain medications in obstetric patients because we don't want these medications to cross placenta because then it would be a little bit more difficult for us to know if your baby is having a harder time breathing. So in the context of plastic surgery, we rely a little bit heavier on sedatives, and that way we can place epidurals once you're sleeping.
Oh, that's a relief.
Yes. So epidurals can actually be placed under conscious sedation or once you're sleeping. So you don't have to be awake or necessarily be awake for this surgery. I mean, for the placement of the epidural. My point being here is that you can actually even be cooperating and awake, but not necessarily recall the movement or recall actually being cooperative. This is a very, very important subject because this is called anterograde amnesia. It's one of the reasons that we use conscious sedation for. Okay. Conscious sedation is one of the steps that we have so that whenever we are under sedation, we can still follow orders. Okay, so we use this to achieve a point where we can still follow orders and have the airway protective reflexes like coughing or deglution, having them present while we still are working by placing a block.
Right.
And then once we place the block, we will set into general anesthesia. This is usually the way. But depending on how your body responds, depending on how the experience you have, can also determine how you work on placing the epidurals themselves or not. If you place them towards the lumbar vertebrae, the thoracic vertebrae. For example, I really like using thoracic epidurals to block off thorax, because since most of our surgeries have very, very high dermatomes that we're working with, like our breasts, or whenever we have upper body lipo on our back, I usually want to protect all these dermatomes. So using a high epidural through the use of a thoracic epidural, I can achieve this type of block. But, it doesn't necessarily fall into everyone's favorite cup of tea, because blocking the thorax itself has very sensitive tissues around. We have the lungs, we have the kidneys, we have the aorta, we have there's different challenges when placing thoracic epidurals instead of lumbar epidurals. So they're not everyone's favorite, but I really like them because they're really really soft, and I really like how they behave.
Right. I think that's going to put a lot of people's mind at ease, because I think when people hear epidural, they're like, I don't want that. But I think it's also because that they just think they're going to be awake and a needle, so I think that's definitely going to put a lot of people's mind at ease. Speaking of, again, like I said in the beginning, a lot of patients are very scared of, this is really the only scary part of surgery for them. And why do you think that is? And how do you calm their nerves before surgery?
Okay. So whenever we come into the pre-anesthetic consultation and we, are usually anxious, I can see it in most of our patients' faces, right? When we're feeling anxious about not waking up or wanting to know something. So I would usually address the issue. Like, are you scared? Are you feeling anxious about tomorrow? Is there anything that is particularly making you feel worried, or, having this sense of angst? So usually what I tell patients that as a first line of like steps to take, or steps to follow, is the fact that we always use revertible agents. All the medications that I'm going to be giving you for anesthesia have revertible agents. Okay, so this means that they have like a specific antidote. Okay, so for example, benzodiazepines have flumazenil, and opiates have naloxone. Neuromuscular blockers have sugammadex. So most of the molecules I'm going to be giving your body have revertible agents. So this is when you evaluate during pre-anesthetic consultation if your patient does or does not have predictable factors for either difficult airway ventilation, difficult airway intubation, maybe a difficult block. If your patient probably has maybe, for example, one kidney for some reason, I would probably start to think about switching into things that are not metabolized by kidneys. So this is where you start planning and making your anesthetic plan on how you're going to be using medications to make sure that you can be safe to ensure that patient that they are going to wake up.
Right.
Okay. So, and since it's different for everyone, you want to know everyone's background precisely. And that way I can give you the comfort of letting you know how you're going to be waking up. And if for some reason, because this is also very important, if for some reason there is a harder time or a harder possibility of me providing that guarantee, I have to tell you about it. Because anesthesia deals a lot with how we explain risk. Risk is the ratio of possibility to probability. possibility is something that will always be there. I cannot remove that, right?
Mm-hmm.
As much as I try, I cannot remove that. But probability, on the other hand, is something that I can work with.
Right.
So whenever I know that you have things that are prone to happen, and this is why we have all these scoring systems and all these preventative scoring and all these preventative tables and measures. So whenever we know that something is prone to happen, if we take adequate measures to decrease the probability of this happening, it should not happen, or at least fall into the same probability as the global population. This means that, for example, if you and I were global population, means if you and I were to go into the same surgery, we should have the same risk of things happening to both of us.
Right.
Okay.
You guys play such a huge role in surgery. Like it's absolutely like it's mind blowing. So now you've met with the patients the day before and you've met with them before surgery. Now you're in the OR. Let's talk about what happens. What are you doing? What are you monitoring during surgery time for the patient?
So the first thing what you do when you get into the OR is I really, really like to ask my patients what kind of music they like.
I love that.
I really like asking them if they would rather listen to something in particular or if my music is okay. Because I really like to listen to music softly as we are working, usually as we are either intubating or under the process of sedation or monitoring. So usually music plays a very important role because it will also decrease your natural endogenous adrenaline. So the moment you walk into the OR, there's already music playing.
So you're also a DJ, basically.
Yeah.
Nice. Nice.
And what I say to our patients, even from the day before surgery, is that I want part of the intention of having pre-anesthetic consultation on the day before surgery is that when you are brought into the OR by the circulator nurse, and you see either me or Dr. Rios, then you know you're in the right place. Because if you haven't met any one of us, then you would probably be like, I don't know who any of these people are. And I am also, in a different country. I am having maybe not necessarily a strong language barrier, but there's a cultural language barrier, and there's a lot of other barriers. So the moment you walk into an OR where you see a familiar face, this will just immediately make everything feel a lot better.
So much better.
Yeah.
So I got a little bit of an off the wall question, but off the top of your head, what is like one of the most memorable songs that you've been requested to play?
Let's see, memorable songs that I've been requested to play.
Yeah, or craziest type of music that you just weren't expecting that.
Some people have asked for reggae, which is really strange,
I know, I totally get that. It's so like just chill.
Yeah, it's really chill. And it's also because, maybe you're not, the OR is always cold in the morning. So maybe, and it's maybe like, 7:00 in the morning. So maybe you're not necessarily expecting to listen to reggae at 7 in the morning.
Bob Marley.
Yeah.
Don't worry about a thing.
Yeah. So that's probably something I can remember, right? Yeah.
That's awesome. What's your music of choice that you play? If someone is just like, whatever you want, what do you like to play in the OR?
I like a lot of electronic music. Probably,
nice.
I think that I like The Blaze. I like Roykstorp. I like Miami Horror. What else? But I can usually switch between, pop or a little bit more electronic music, like maybe even Daft Punk.
Right,
I will usually, a little bit more upbeat music. And also, I think that this plays a really crucial part because when the surgeon comes in, because and then Dr. Rios and I have been working for, we've been working together for so long. It feels like placing or playing everyone's music or everyone's mood type, and usually allow them to shift and give everyone a little bit of a moment of having their own music, or maybe we've made like today's surgery or today's central part of surgery was rock, and we tried to branch out of rock into rock with country, or rock with electronic music, or maybe rock with something else, and sort of branch out. And that way we will, have covered most of the areas. And sometimes maybe you have a special request, like I really want to listen to this song. So
I would be like, put me asleep to I'm a Barbie girl.
Yeah. So we've done that,
and take requests.
I take requests, and I ask patients if there's something that they would like to listen to before they are going to sleep.
That's awesome. I heard Dr. Rios is into like a little bit of, is it like alternative, like rock?
Yeah.
He's like into really all that. Like
Dr. Rios likes Avenged Sevenfold. We use Disturbed, maybe Eminem and Papa Roach, and so there's some different kinds of music that we play for everyone. Yeah,
that's so cool. I would never pick that for him. Like, just by looking at him, I'd be like, okay, interesting. So how long do, on average, let's just say someone's going in for like the mummy makeover, the big 5, how long are people out for?
So usually we measure time a little bit differently. Anesthesia starts before surgery starts, then surgery ends, then anesthesia ends, then recovery starts, then recovery ends, then the recovery of anesthesia ends.
Right.
So as you can see, anesthesia is a very long process. But most of the time, I would say that a given surgery, in hindsight, it will probably be around 5 hours to 5 hours and a half. That is probably 5 hours. I would say 5 hours is probably our safe, go-to. That's probably something I would say. Yeah.
Surgery time. And then how long after surgery time does it take for them to wake up? How long are they in recovery for?
So this really depends a lot on how and what type of anesthetic technique you use. For example, the type that I use, since this is called multimodal anesthesia, the moment that surgery ends, usually by the next 2 to 3 minutes, you are already breathing on your own and awake and talking.
Nice.
Yeah. So that way I can ensure that I can ask you if you're having any pain, if you are, under any distress, or if you're feeling comfortable. And patients will usually be like, well, I'm fine. This type of surgery and this type of anesthesia really, really go, they go together really, really well. So they will use, our patients will stay in recovery, not necessarily because they have to recover from anything, but just to make sure that they are monitored enough and to make sure that they are breathing correctly and that they will not require any assistance once they are moved back to the room. Because once they are moved out of the surgical area, there is rarely any other anesthesiologist available upstairs or somewhere that is not near the OR. That's why we usually say that it's so rare to see an anesthesiologist outside the OR. And anesthesiologists are very, very important in the sense that we are usually the ones that have the expertise of controlling the airway and making sure that you can breathe and making sure that you that your heart is beating correctly or not changing rhythms, or that your blood pressure hasn't dropped too low, or that it hasn't spiked. So usually this is why you would stay in the recovery room a little bit, longer. But I would probably think that maybe 20 minutes to 40 minutes should probably be enough, depending on the type of surgery and the type of anesthesia that we use.
Gotcha. And are you with them during that time, or is someone else with them?
Usually, if my patient is awake, alert, and with no pain, and they can voice all their commands, I will leave them at the recovery room, take their last vitals, like from the monitor that I'm going to be able to see. And that's when I will walk, back maybe into the OR just to make sure that I've turned off the machine, turned off the oxygen and everything. They're not left alone. So there's always someone there. If it's not a nurse, it's probably also a doctor. So it could be a nurse, it could be an MD. But that's usually who is taking care of them before they are moved out to
their room. That's really cool. And let's talk about pain management. So after surgery, I'm just speaking from personal experience. I had no pain.
Excellent.
I'm like, what on earth did they give me? Like I wouldn't have even known, like, especially like for my boobs, I wouldn't have even known I had anything done unless I looked down and I was like, oh, wow, they're there. So how do you guys manage to do that?
So I'm very happy to hear that. I'm very, very happy to hear that because, pain management, it's 2025 and this is, after all, elective surgery. So even if it's, even if it weren't elective surgery, there is no place for surgery to be painful.
Right.
So my point being, surgery or recovery from surgery could be uncomfortable, but it should never be painful. Surgery should not hurt you ever. It shouldn't. Okay. So we have to build on that, right? So this is where pre-anesthetic consultation also becomes so important. The more that I get to know you during your consultation with your anesthesiologist, the better that I get to understand how you perceive pain. And the more that I understand how you perceive pain, the better that I can make pain medication work for your body instead of the other way around. So the intention of this is precisely to divide pain into, for example, we have pain indicators and pain predictors. Okay. So for example, someone who has very, very high levels of anxiety, or someone who perceives that their own pain threshold is higher than the rest of the population, those predictors will probably be telling me that this patient will require some kind of either alternative or additive or some other synergistic medication added to their normal combination of medications. Patients who, on the other hand, tend to try to tough it out or try to forget about the pain. These patients, even if they feel that they can manage pain adequately, we should also protect them from the pain, right? Because as we age, we feel pain more, but also as we age, we're more used to the pain. So this is some kind of vicious cycle we should break out of. And knowing how to manage pain correctly, this is something that you need to build on. So what it is that you were given depends basically on the sum of your pain predictors and your pain indicators, how your body was actually behaving through surgery. We can only see this through surgery because this lets me know if your body was requiring more pain medication or more medication to block off perception. Okay. So depending on how we have combined techniques or how we have combined medications, we can usually achieve an adequate control of pain. Pain is always easier to prevent than it is to control.
That's right.
Okay.
Yeah.
So staying ahead of the pain and allowing medications to synergize and to correctly add them up or use their properties correctly will allow us to diminish the dosing that we need to use to achieve the same kind of effect without giving you most of the side effects. Okay? Because also, the stronger the pain medication, the stronger the side effects. So sometimes whenever we are having really intense pain, we will probably use strong medications. So strong medications can actually give off maybe, for example, really intense nausea.
Yep.
And for anyone who has history for medical history for weight loss surgery, having nausea or dry heaving can actually be even more painful.
Yeah.
So that is actually even more distressing than the fact of having the pain. So then you have now you have two places you need to block off pain from.
Yeah.
So adequately knowing your patient's background and adequately knowing how medications work and which alternatives behave better for who or for what type of patient, this is where you get the real benefit of pre-anesthetic consultation. So this is why it's so important to meet with your patient before going into the OR. And something that I think that we were not used to knowing is that as patients, we have a say in how we want our pain to be managed, right? We have a say in this because it used to be very, very old school for having, just someone decide what type of pain medication you should have and how much and how many, and that was it, right? And, maybe if we were to still be in pain, older generations of doctors would probably say something like, maybe that's just, I can't give you any more medication. I can't, you've already had too much. So this type of thinking is, there's no fitting in this type of thinking in 2025. We should think of adequate models of pain relief. And this is one of them, and the most correct or the most recommended one is called multimodal analgesia. So it's the addition of more than one type of pain relief technique. It can include the use of NSAIDs, the use of neuromodulators, the use of opiates, the use of blocks, the use of potent opiates, the use of a lot of other stuff, magnesium, the use of lidocaine. So there's a ton of stuff.
Yeah.
But usually my point being is that we should not be in pain, and you actually have a say in how things hurt for you, right? Because for example, even if I studied pain, I can't tell you how pain hurts for you.
Right. Everyone's different.
Everyone is different. And the only thing that I can do is provide adequate pain management for your pain. But so here's the risk of this. We don't want to undergo something that is called pain masking. Okay? So for example, pain masking is when if you are having a type of pain that feels maybe like I come visit you, right? And you are maybe in pain, and we would probably usually ask you, are you having any pain? You would probably say yes, maybe like a 4 out of 10. It hurts really bad. It's like a burning kind of pain here in my chest. And then I would ask you, do you think this pain could get any worse? And then you would say, this is actually the strongest pain I have ever felt. Okay. And I give you pain medication that is made for the strongest pain that can ever be felt by someone like you. And this was actually more of a subjective response.
Right.
It would probably move all the pain markers all the way down to zero and even pull them further down until it would probably make you sleep. And this is called pain masking. If I give you pain medications that are either too strong or pain medications that are too long acting, we would block off the pain and you wouldn't notice anything at all. And pain is also a warning sign. So, for example, if you were to pop a stitch, if anything were to go awry, if you were to have a hematoma, if anything were to happen, the first thing that you'd notice is pain. Right? So we don't want to go into pain masking. We just want to be able to have enough perception as to understand when something is being uncomfortable, but not painful.
And that's exactly how I explain it, because everyone's like, oh, it must hurt so much. I'm like, it doesn't. It's just discomfort. It's just, it's discomfort. It's not painful. So it makes so much sense that you say that.
Yes, exactly. So we need to prevent the pain masking. And so this is the type of, for example, whenever we're having a pre-anesthetic consultation, this is why I like to teach our patients this, maybe I will usually tell them, try to imagine that you are lying, in your bed, in your recovery, and you're on your phone and maybe you're scrolling. Maybe you're reading or you're on your bed and, you're just on your phone and you feel you want to go to the bathroom. And then by that moment, you feel that you would rather hold it in, right? That is pain. Because normally you would have stood up at the first call. Okay. It's just your brain tricking you into thinking that it's something else.
Right.
Okay. So, this is what we try to avoid. We want enough pain control for you to be able to stand up at the first call if you need to, okay? Because we need rapid movement and rapid reinstallment into your daily activities, like moving around and walking around, in the hallways. We need this because we also want to prevent the blood clots. Okay? So if you can move, if you can't move adequately, then because of the pain, then your blood is going to pool easier and it's going to probably make it easier to clot. So we need the movement. And in order for us to move, we need adequate pain control. So adequate pain control then requires staying ahead of the pain and having enough pain understanding. So pain can be derived from our nerves, like nerve pain, like neuropathic pain, for example. Pain can also come from our muscles and our joints, like somatic pain. And the thing about surgery and about plastic surgery is that it can give off a lot of different kinds of pain. Okay. So, for example, the pain that we expect in a breast lift is a lot different than the one we expect in muscle repair.
Right.
Okay. So understanding how these types of pain can feel differently is very important because they can be relieved by using either different types of combinations of medications or different types of techniques.
Yep. Makes sense. That makes a lot of sense. So, if a patient is, getting ready to have surgery, is there any kind of like medications you recommend that they stop taking? How should they better prepare themselves for a surgery like this?
Okay. So something that is very important is that I was actually listening to the interview you were having with Dr. Rios earlier this morning.
Oh, nice.
Yeah. And I was listening to that, and he says this also. Whenever he gets a case and he reviews the case, part of this reviewing involves deciding how we're going to be recommending that patient to continue taking some things or stop taking some things or continue doing some things or stop doing some things. So the same thing happens on the anesthetic side. Whenever the surgical side has performed their evaluation, they will usually pass it on to our anesthetic side. And this is where we come into play. And then we decide what helps us and what doesn't help us, and how we can titrate, continue, discontinue, and recommend before going into surgery. And this is when we usually will ask our patients, please let our coordinator know that this patient needs to tell us if there's any new changes into her or his blood pressure medication. Let us know if there is any way that you can stop this medication and change it for some other alternative. Okay. If not, just let us know so that we can plan for it. Okay. For example, someone who is, this is just an example, right? Maybe someone who is on chronic or medical marijuana for pain control, right? I would probably suggest getting off the medical marijuana, switching it, and consulting with their pain physician to switch it maybe from marijuana into probably an opiate or something that controls pain adequately from another family, so that I can then work with that once you're here.
Gotcha.
Okay. And then once you're back home, you can switch back if you need to.
Right.
And then this will allow me, once you're here, to make adequate recommendations, like having either pain patches or pain pumps, or deciding on how much your pain indicators are going to be, how high they're going to score, right? And that way I can warn you, for example, if you're having, and we're just using this as an example, right? Maybe if you are a patient who is having marijuana for pain control, I can warn you that pain control for you is going to be a little bit difficult. And then maybe the best way to go would be to have an underlying continuous release patch with maybe orally taken medications to prevent spiking. Okay, so we can design a plan that usually will work for you throughout your recovery. It will be different for everyone.
Yeah, I love that. So you guys listening out there, please be very honest on those health questionnaires, because everybody looks at them. Dr. Rios looks at them. You guys look at them. And that is how they determine your surgery plan, your recovery plan, your pain management, and all of that. So please.
Particularly your heart. Your heart. There's something that we really, really, really want to, that as an anesthesiologist, I would really want to stress. Whenever we have exposure to any recreational activators or recreational THC or CBD, usually this can affect how our heart can cope with the changes in surgery. So maybe having enough time of having stopped using them will allow us to have less of an impact on your heart.
Right. So the more you list, the more they know, the safer you are. So don't leave anything off. Dr. Juan, you have been an absolute delight. And
Thank you so much.
And such a ball of knowledge. And I think that you have probably put a lot of people's mind at ease. Is there anything else you want to add that people should know before they come, or anything that you want patients to know? Or did we cover everything?
I think that I would always want patients to, do their research. I would definitely encourage patients to do their research on the surgeons they're having. I think the EOC group is such a great group of professionals. I think they all have, they have wonderful ways of doing things. So I think that I would suggest to all our patients who are coming to do all your research, see who you feel understands you the most, who you feel you want to follow you the most, or follow you throughout your your recovery, or your or the way that you are feeling that you are getting better.
Right.
So also, I think that something that is very important is the distinction between the plastic surgery side and the bariatric side of anesthesia.
Mm-hmm.
So even though anesthesia is, for everyone and for everything, we've mostly covered most of the, anesthetic side of plastic surgery.
Mm-hmm.
But what I would want to stress most is that we work for your safety.
Mm-hmm.
Okay. So even if you are focusing a little bit more on the bariatric side of surgery, or are barely starting your journey, or if you are, midway through your journey or almost done, what I want you to know is that your safety is always our main concern. We have seen patients here that we have not stopped, but we have usually deepened their, that's the word I was looking for, deepened their study of something that maybe they didn't know they had.
Right.
So, for example, maybe someone will be or say something like in their questionnaire, right? Maybe they will be like, I used to have palpitations, or maybe the last time someone told me I had, I don't know, just some heart thing that was studied because when I was pregnant, I had high or low blood pressure. Okay. So if we read something like this, we will definitely look for the best way for you to get studied so that we can deepen the most, or the best as we can, the understanding of what is actually going on, so that we can perform a safe surgery.
Yes.
There is nothing more important for us than a safe surgery, because safety is definitely the key to an adequate recovery.
Yeah.
And we need patients to understand that you as a patient are the key to keeping yourself safe.
Yep.
Okay.
Exactly.
So exactly. So safety is definitely the one thing I would stress the most, and you are the key to keeping yourself safe. That is what allows us to build on your safety, so that we can study you more, so that we can understand you better, so that we can make a better surgery for you.
Yeah, that makes sense. Because sometimes I hear people say, what happens if once I get to Mexico, and I hear this in the bariatric page and the plastic pages, what happens if I get to Mexico and then all of a sudden I get turned away? And it's like, well, it doesn't happen that often, but it does happen, right? And it is because of your safety. If something is not adding up, or something is not safe before surgery, it's not like you're going to get turned away forever, but like, hey, this is not the time. You need to go home and do X, Y, Z. And sometimes you guys even find out things that patients don't know about themselves. And then they need to go home, correct it, go to maybe cardiologist or whatever it may be. So you guys really are lifesavers. You change lives and you save lives, because sometimes people come and they don't even know that something's wrong with them. And sometimes you guys find it out before anyone else. But it's never like, oh, well, you wasted your money, you get turned away and you can never come back. No, you guys give them a plan. Like, hey, you need to go home, do X, Y, Z, come back, and then it's going to be safe. So I love that about you guys and every surgeon in here. So bariatrics, plastic, you're all extremely thorough. And it is because safety is the number one priority. Obviously everyone wants, their surgery and everyone wants to look good, but, there's no use of doing that if it's going to be a risk. So I love how thorough you guys are. So thank you so much for all of that information. And you guys, when you are picking a surgeon, you can't go wrong. They're all amazing. But also remember, you're picking a surgeon and you're picking a whole team. And so thank you for coming on here and representing Team Rios.
Rios, I'm here for that. So
I seen the little TikTok you guys made coming out of the the hallway.
Yeah.
I think it was yesterday. That was really,
It's been
really
really
cool.
nice. It's been really nice for us, and it's been really nice for us, and it has brought our team, together, and we really like that. And I think that, it feels like working with friends.
Mm-hmm.
Yes. There's something, I would definitely want to mention is that I have the absolute privilege of coming into work with my friends.
I love that.
I mean, I've been working with Dr. Rios I've been working with Andre for so long now.
How long? How many years?
So I started anesthesia when I started anesthesia in 2014. And I think that the first surgery I had with Andre was probably when I was in 2000. So it was 2015. So it's been probably 10 years ago.
That's cool.
Yeah. And, and how we met was actually a really, really nice story because I saw that, it was one of the questions that you wanted.
Yeah.
So the short story of this is, when I had just graduated from anesthesia. Anesthesia is it used to be shorter, and it was 1 year shorter back then. So I graduated. I had just graduated from anesthesia, and I had just come back from my pain training in Barcelona. So I was working with Andres. He was in his last formative year, right? So I had just finished, but he was in his last formative year. And he was working with his teacher, and it was his last formative year, and he was doing it was just before he started his body contour, right? Because he then came over to Tijuana, and he was then doing some rotations with Dr. Lazos. So at that point, that particular moment in time was the game changer. Right. Because at that moment I was working with his teacher, and we were having a surgery together, and it was particularly a body contour surgery. So much more different than the ones we do here. And I remember that one of the things that happened was that I had performed one of the blocks that I learned in Barcelona. I had just done a differential block. A differential block means that I can remove pain without blocking off movement. And I had used a double block technique, which is something that almost no one does. It's very rare to be seen because I had blocked off the upper part of the body and the lower part of the body differently with different catheters. So the point was that the patient was not intubated, and we were doing body contour, and they were performing liposuction. So the patient, she tried to make herself more comfortable, and she crossed her legs, like one on top of the other, right? So the circulator nurse actually became very scared because she was so unused to patients moving during surgery. She was like, "Doctor,
what's going on?"
Yeah. So Andre's teacher, he just lowers the curtain, and he said, "Juan, is everything okay? Are you sure that we can keep on operating?" And I made sure for him to see that I uncovered the patient's face, and I asked her. I called her by her name, and I just woke her. I tapped her shoulder, and I woke her up, and I said, "Are you all right?" And she's like, "Yeah, I'm fine." And I said, "Okay, could you please uncross your legs, because it's a little bit harder for to work if your legs are crossed." And she said, "Oh yeah, sure." So she uncrossed her legs, and then I said, "You can go back to sleep now if you want to." And she's like, "Oh yeah, I'm sleeping really, really nice." So she went back to sleep. Nice. And then after this, it was like, what just happened?
You're like, right? Who is this guy?
Yeah. So then after this, Andre told me, we all want at some point to grow out of the out of the shadows of our teachers.
Yeah.
We owe them what they taught us, but we want to become. We want to grow with them, right?
Yeah.
So he told me, in the future, I am moving to Tijuana, and will you come with me? And I said, sure. I will definitely come with you if this is like a serious thing, then I will definitely move. And that's how that happened. I then started doing the cardiovascular part of my the last stage of my training and everything, and then I moved cities and a lot of other stuff. And then by the time that I was in Mexico City, and Andre had finished completely his training and he moved here, that's when I received the call that he had moved, that he had finally moved and was living in Tijuana, and that he was ready to start a team, and that he wanted me on his team. And when could I, come back to work? And I said, as soon as you want me there.
I could be there tomorrow.
Yeah, I could be there at any moment. So we agreed and we have started. We started working together. Our first surgery was the 2nd of August of 2021.
That's great.
And we have worked nonstop since that day.
I love that. I didn't know that. That's such a cool story. Thank you for sharing that. Oh my gosh, I love that. Yeah. As soon as he seen that, he was like, oh yeah, I need this guy on my team. That's cool. Very cool. Well, thank you so much for joining us today on this episode of Bariatrics and Beyond. And you guys remember this face because it's going to be the first one and the last one you see when you wake up.
Yes, I'm very, very happy to see you. And, nothing makes me more happy than to actually meet someone new and being able to tell this person, right? I'm meeting you, so nothing is more important to me than to tell you that you will be safe.
Yep.
I will try my best to make you feel comfortable, and I will do as best as I can and to the best of my knowledge and the most that God has given me to bring you back home safe. And this is what I like about my career.
That's amazing. You're not only talented, but you're super compassionate and personable. You're just a gem. And thank you for being part of the EOC family.
Thank you so guys so much.
Awesome.
Thank you for giving me this opportunity.
Oh, it's my pleasure. Thank you for joining us. And you guys, we will catch you next week on the next episode of Bariatrics and Beyond. Bye for now.